again, thank you for joining us. Charlene, please join us.
Thank you, Doug, and thank you, Maureen, for all your help in putting this all together. You two are invaluable. I'd also like to recognize some other invaluable members of the committee who have been very active in helping put this program together. Maureen Hurton, Mary Lou Woodford, Glenn and Christy Badger, and Tracy Driscoll. Thank you all so much for all your hard work on this. And now it's my honor to introduce first Mark Peterson. Mark is the VP of Interim Healthcare of the Northeast, and he is the generous sponsor of this educational series. Come on down, Mark Peterson.
Thank you very much, Charlene. Again, happy to be here. My name is Mark Peterson with Interim Healthcare, part of a third-generation family business, started back in 1979, and we blend the size and scope of a national franchise organization with local ownership and local decision-making. We're headquartered in Manchester, New Hampshire, with 8 locations between New Hampshire and Maine, and our provider of home health, supplemental staffing, and private duty services, and serve a number of elderly patients throughout Maine and New Hampshire, helping those folks to remain in their homes as long as safely possible. And we're also the largest provider of pediatric services in New Hampshire. We are a very proud partner of the Case Management Society of New England and thrilled to be a co-sponsor of this conference. Understand we have some fantastic speakers. We're look forward to hearing that, and look forward to a great conference. Thank you, Charlene.
Thank you, Mark. And now it's my honor to introduce Teresa Hayes. Teresa is the Business Development Director from Encompass Health and also a generous sponsor of the continuing education credits for this series. Teresa?
Thank you, Charlene. Hi, everyone. It's my pleasure to represent the 9 Encompass Health rehab hospitals across New England. The exact locations are here on the slide. The map kind of gives you an idea with 6 locations, actually 7 locations in Massachusetts, 1 in Portland, Maine, and 1 in Concord, New Hampshire. And just briefly about who Encompass Health is. We are inpatient acute rehabilitation hospitals. We follow evidence-based clinical practice guidelines to develop our rehab program and the services that we provide to patients. As Mark said, it's really our pleasure to have been a corporate sponsor of Case Management Society of New England for many years, and also to be co-sponsors of this particular program. If you know us, and give us a shout out, and thank you for the collaboration that you've given to us over the years and referring patients who need inpatient rehab. If you don't know us, I encourage you to give a call to one of the locations, or reach out to Maureen if you need my email address, or visit us on the web so that you have a better understanding of the role that we play as inpatient rehab hospitals in the post-acute spectrum as your patients are needing further comprehensive services. So again, I look forward to the speakers tonight, and I just want to thank you for giving us the opportunity to speak a little bit about who we are. Thanks a lot, Charlene.
Thank you, Teresa. I am very fortunate to know all 3 of the panelists who will be joining us tonight. They are amazing people who are so well respected in the field of aging for their vision, their work, and their dedication to making the aging process better. So first of all, meet Jamie Sanford. Jamie is a dynamic project champion for the Lynn Health Navigator, a program so innovative it won $1 million CARES Act grant. In her day job, she's administrator of Lynn Health and Rehab in East Providence, Rhode Island, and has years of medical social work in long-term care, hospital, and hospice settings. Paul Lanzikos is a former executive director of the North Shore Elder Services and the Executive Office of Elder Affairs Cabinet Secretary. In 2020, Paul became one of the founding architects of Dignity Alliance Massachusetts, a coalition of disability and senior advocacy organizations formed in response to nursing home deaths. DAM's aims are to advance policies that revolutionize long-term care, putting the dignity of individuals first, ensuring affordable options for community living, and providing living wages and benefits for caregivers and service workers in facilities and home and community-based settings. Paul and Irving have also worked together, creating home-based and community-supported care delivery programs. Irving Stackpole is our moderator tonight. He is an experienced visionary, and in 1991, he established Stackpole & Associates to guide clients through each phase of marketing and business development strategies by the application of scientific marketing principles to create innovative and practical solutions to the challenges facing organizations in this rapidly changing market. In 2020, recognizing the need to transform what life in a congregate care setting should look like and the necessity of investing in home and community-based services, Jamie and Irving were part of the team that wrote a winning CARES Act grant in the state of Rhode Island. Thank you all for being part of this amazing program, and thank you for joining us tonight. And now I'd like to turn it over to Irving.
Thank Maureen for inviting us. I want to thank the CMSNE for hosting this event. And I want to also thank Charlene, who managed to herd the cats and get us all here in the same place at the same time. First of all, and I also want to thank whoever selected that picture of me that makes me look significantly younger than I actually am. So a lot of thanks all around. The title of this program is really, says so much, and I want to just frame what Jamie and Paul will be talking about by talking about the challenges associated with bringing care, arranging care, managing care, accessing care. And the Case Management Society of New England is in an ideal position to be part of that enormously important transition. The transformations that are taking place are oftentimes in reaction to immediate events like the pandemic. But here we have two visionaries with us tonight who've seen even past that particular hurdle to the underlying structural flaws, the underlying structural issues in the management and delivery of care. We all know the data. We don't need to have a long time conversation about that. 20% of the populations that we work with consume 80% of the resources. How do we address those issues? This isn't a theoretical conversation necessarily, although we'll extract theory from it. We have two very practical programs. We'll have Jamie talk about the Lynn Health Navigator and Paul talk about his innovative program as well. So we're honored to be here, and our sincere hope is that this is really just the beginning of an engaging and in-depth conversation. Please feel free to use the chat box, or actually I guess I'm supposed to say the Q&A function, to ask us questions, pose questions, which we'll tackle at the end of the program. And with that, Jamie.
Good evening, everybody. Thank you so much for having me here tonight. As Irving said, my name is Jamie Stanford. I am a licensed nursing home administrator, as well as a licensed clinical social worker here in Rhode Island. I am going to share my screen now. Okay. So today I'm going to be sharing Lynn Health and Rehabilitation's response to the COVID-19 pandemic, the challenges we faced, and how we rose to meet those challenges. It is no surprise that the coronavirus pandemic has hit the hardest in the nursing home communities across the nation. The design and architect of nursing homes were not constructed to care for those infected or protect residents from a worldwide infectious disease pandemic. Those residing in long-term care facilities are the most susceptible to illnesses, as we know, yet they often reside similar to college freshmen in like a dormitory type setting. They reside in shared rooms with shared bathrooms, and they utilize communal showers. This is the worst possible environment when trying to prevent the spread of an infectious disease. More than 32% of COVID-related deaths occurred in the nursing homes. And this is just absolutely devastating for our industry. I started my career as a long-term care administrator in May of last year. Talk about trial by fire. I felt like we were getting hit from every angle when I started thinking about like what challenges I faced within the last year. To be honest, at that time, we didn't know what COVID-19 was. We were all learning this together, the CDC, health department, and healthcare providers along with society, where we were learning together. So this unknown caused for constant changes in the CDC and Department of Health guidance to us. And it required constant changes of policy, procedure, and education. I recall it was probably my first week here at Lynn Health. We received guidance from Department of Human Services. Okay, this is what our guidance is to combat this infectious disease. My team, we huddled immediately. We knew we had to act quick. We huddled, we developed a plan, we executed the plan, we educated our staff. By 4 o'clock that same day, new guidance, taking back the previous guidance at 11 o'clock. So talk about challenging. We also experienced staffing shortages, as most did across the country. We had to lock down our facility. When we started talking about COVID last January, I remember hearing a lot of long-term care administrators and social workers and directors of nursing. We were, this wasn't going to affect our community. Why? We were going to lock it down. We're going to lock it down, keep everybody out. That was not the case. That was not the case. So we did lock down, but that we also had to change the way that we communicated with the families. Yet again, another challenge. We started fighting that virus, and we watched it take the lives of our residents, our family members, and we went through the grieving and mourning process. And if that wasn't enough, at the end of the day, we were faced with reality. We lost our residents, both from the virus, others from wanting to just charge back to the community to feel safer. And the end result was a drop in census. So at that point, it became survival. But we were not alone. Most facilities were devastated by low occupancy. We had to change the way that we marketed to the community. We weren't allowed in elderly housing or senior centers, adult day services. We weren't allowed in hospitals or primary care offices. And to be honest, the society didn't want to send their loved ones to a nursing home. So at that point, nursing facilities here in East Providence, there's 9. The competition is so high in the very, very small city, 9 nursing facilities. We were all fighting for the same referrals, and we were fighting for the same staff. So the result, the Office of Health and Human Services, they engaged in discussion over readdressing supply and demand. At the end of the day, that's what it was, supply and demand. And through the CARES Act, the state of Rhode Island, long-term care services and supports resiliency program featured a need for greater flexibility and innovative programs to safely transition individuals. The leadership team here at Aldersbridge and the clinical team at Lynn Health, we jumped to the opportunity. We knew we had to reimagine and transform how we provide care to the most vulnerable population. We needed to do more. Knowing the current design of the semi-private rooms presented significant risks to our population, Lynn Health developed a work plan. And our work plan included transforming 11 semi-private rooms to private rooms, essentially deservicing 11 beds. The plans included improvement in infection control, addressing state-of-the-art ventilation, air purification, as well as providing private baths and private showers. We knew if we had the availability of rooms like this, we could care for those infected and have a place for those infection status that were unknown to house. We also knew we couldn't stop there. We needed to do more. So the resiliency program featured a need for greater flexibility and innovations, specifically to transition individuals from one setting to another, focusing on the individual's self-determination in choosing their preferred residence. As a social worker, I sat by the bedside of my residents for 15 years, and that was always something that I spoke about. If you could close your eyes and receive the care that you want, where would that be? A lot of times it was in their home. Unfortunately, there is a gap in services that we don't have the availability to provide that care. So that's what we addressed. And this is where the Lynn Health Navigator was born. Last fall, as Irving and Charlene spoke about Lynn Health and Rehabilitation, we had the opportunity to apply and was awarded the Nursing Facility Transformation $1 Million grant for our private room transformation and innovative community-based care management program. Lynn Health Navigator was geared to provide a proactive as opposed to a reactive response by assisting residents navigate the complex systems to service connection. I think as society, we tend to react. We come from a reactive standpoint when considering the needs of our elderly. And that needs to change. We shouldn't wait for a negative outcome like a fall or a CHF exacerbation. We shouldn't wait for events like that for our elders to receive the services that they deserve. So we looked at all systems in place to protect elders. And what are those systems? It's housing, it's transportation, it's medication, heating assistance, food, medical, behavioral health. I mean, the list is ongoing. As a social worker, I've listened to family members. I've listened to my residents, both in the facility and residents I discharged from the facility, how overwhelming that process is. Even my best discharge plan, once they left the facility, the process is overwhelming. It's overwhelming for us as social workers and case managers and care managers. Can you imagine what that's like for an elderly resident and or their family to navigate the system? So we all know it's not uncommon for individuals to avoid tasks, right? To avoid tasks when we're overwhelmed. We all do it. We do it ourselves. And when we're talking about avoiding needed services, it can result in negative outcomes for someone's health. And those include rehospitalization and unnecessary emergency room visits. So our hopes by developing the Lynn Health Navigator is to protect and prolong our residents, our clients, their ability to maintain their primary residence in the community. So let's talk about, what is one of the major obstacles. One of the major obstacles, I think, in the United States healthcare system is our ability to communicate amongst providers. For the purpose of this program, Lynn has identified potential solutions by applying technology to address interoperability. This technology is going to focus in on transitions of care. So we're looking at an individual going from the hospital to a skilled nursing facility, from a skilled nursing facility home to the community, and how do we all connect to ensure we reduce any potential negative outcomes. We are hoping that this is going to, this technology is going to enhance communication amongst the providers and improve overall health outcomes for our consumers. So what's different? What's different about the Lynn Navigator? Well, the Lynn Navigator, we go from a proactive response. We're in there, we're assessing risk, and we're holding the client's hand through the service connection process. We are doing the applications with them. We are, holding their hand through the transport to get to maybe one of those service provider in the community's office. And we're sitting with them and helping them navigate those conversations. We are helping them obtain, 6 months of bank statements. We all know what these processes look like. And when they receive notice, if they were accepted or not, we take the next step. If we don't get a timely response from a service community provider, we're on the phone and we're advocating for these residents. We also provide services to an array of individuals in the community. It's not going to be based on qualifications. We're all very familiar with the gaps in services in the community. Either you qualify financially or you qualify physically or medically, right? And usually it's one or the other and nothing in between, and individuals fall between the cracks. So our navigators out there listening and responding to those gaps in services, and constantly having conversation to fill those gaps and meet the needs of the elderly in our community. So delivering results, the Lynn Navigator, it's a leader. It's a leader, and we partner with our community to better outcomes for those residing in our community. We're identifying research, we're looking for information systems, and we're rising to the challenge of addressing, the issues with the healthcare systems and having interoperability, having us speak to one another and communicate to one another. And as an end result, I think the outcomes, the rehospitalization, the Medicare rates, they're all going to be reduced. So here is my contact information. Feel free to outreach to me. My email, admin-lynn@aldersbridge.org. I would love to hear from you. Love to have conversation. So I will hand this back over to Irving.
Thanks, Jamie. And as Paul gets his presentation queued up, I'd like to serve up a question for you, which has to do with the theme of the conference, which is innovation through education and technology. So in the community, to the extent you can describe it, what educational barriers are you finding? Are people aware? Are the consumers themselves aware of the services that are available to them and how to access them?
So we have a lot of tools, I think, in the state of Rhode Island. We have a lot of tools to have the information available on websites. But our elderly population, I don't know if they know how to get that information, or how, once they get the contact information, how to navigate to get the services offered. If that makes sense?
Right. I think everyone can most people in the audience can identify with those challenges. And I I admire how you described the program as being proactive rather than reactive, rather than waiting for some precipitating event that would then lead into services delivery or services demand. Your navigator program is intended to anticipate and to prevent. An ounce of prevention is worth several pounds, as they say. So it's my privilege next to introduce Paul Lancikos, who doesn't need any introduction to those who are aware of him as an innovator and a disruptor in community-based long-term care services. So without further ado, Paul, welcome.
Thank you, Aaron. Is that a way of saying troublemaker in polite company?
Troublemaker, yes.
First of all, I want to congratulate Jamie for a very creative, innovative project. You've taken to heart the adage, never waste a crisis. You know, one of the things that struck me for actually several decades now, but particularly in the pandemic, is the way we provide long-term services and care in this country, especially facility-based care, is a model that is now well over 50 years old, probably closer to 75 years old. I've been in the field of aging and disability services for a half century, and that the model that was operating when I first got involved is essentially the same model that we have today in long-term care. So it's time for us to break out that model in the 21st century. And what I'm going to be doing, I've divided my comments into two parts. The first, I'm going to be a little provocative. I hope to be anyway. We'll see if I am or not, in terms of raising some questions around case management, and essentially case management hasn't even changed that much in the last 30 to 40 years, and what could we be thinking about in terms of the way case management functions going forward. And then the second part of my comments, I'll be talking a little bit about how I've been staying busy during the pandemic by helping to organize a virtual statewide organization in Massachusetts called the Dignity Alliance. Okay. And the first question is, what type of case manager are you? Are you the corporate type, or the medical type, or the communication, or are you the deliverer of commodities? Now, clearly, everybody in this call isn't dealing with these types of cases. We use that to talk about people, but why don't we talk about people instead of cases? So during my presentation, we're going to do, thanks to Maureen, we're going to conduct several polls, and this is not only to provide some provocative thoughts, but also to, maybe if somebody's starting to nod off a bit to keep you awake, or if someone's gone into the other room for a cup of tea or something stronger, we're going to be able to know if you're not at your computer screen. No, but so what statement is most appealing to you? I'm looking forward, to being case management. I can't wait to be admitted to a nursing home. I like being told what to do or not to do, or none of these options are appealing to me. So take a moment and put in your put your comments in, and we'll do this for about another 10 seconds, and then Maureen's going to share the results. I have a prediction what most of you are going to say. See how close I'm going to come to predicting this. And the results, wow, we have a landslide. None of the options are appealing to me, and there's a couple souls out there who can't wait to be case managed. No, I'm not talking about going to a spa. I'm talking about being case managed. Okay, so I think most of us want to be as independent and be able to have our options as much as possible available to ourselves. So next question is, who does a case manager work for? Do you work for the payer, Do you work for the provider? Do you work for the client? Do you work for the family, or maybe the friends of a person? Or do you work for a third party, for example, the courts or guardian or attorney? Or do you work for all the above? I'm going to ask Maureen to put this poll up. And I'm not asking who pays you. I'm asking, who do you work for? What drives your work every single day? Whose concerns are top of mind? Is it the payer, the provider, the client, the family, a third party, or all of the above? And we'll have this up for another 10 seconds or so. And see how close you come to what the norm is of this group. This one I can't predict. Well, most of you are saying all of some of the above, which makes sense to me. And I'm happy to say a significant number of you are saying the client, relatively less of the provider and the payer. And frankly, that's what I'm thinking, that's the way it should be. That, well, all of them, which includes the client here, and the client should be the focus of the case management day-to-day work. So what case management does, it's you multitask. That's, I don't have to tell that to this group, but we each sort of have our special skill set. And I'm interested in what type of case manager do you consider yourself? Where are your skills? Are you a communicator? Are you a problem solver? Are you mostly an advocate? Or do you coordinate? You're like the orchestra conductor. Or are you expediter, making sure things get moved from one place to another as efficiently and expeditiously as possible? So let's put this poll up. What's your primary skill area? What are you really good at? What do you see your primary role as a case manager? And you can pick out as many as you want. This is multiple choice. About another 15 seconds. Okay, whenever you're ready, Maureen. The polls are closing. All right, well, this is interesting. The majority of you are problem solvers, and probably all the skill sets are pretty easily divided. My guess is many of you selected many, if not all, of these traits, because I think to be effective case manager, these skills all are essential. But problem solving, is, I probably would agree, is critical. What title do you use in referring to yourself? Case manager, care manager, discharge planner, utilization reviewer, social worker, clinical or nurse coordinator, or something else? Okay, Maureen? Again, this is multiple choice. You could select any, as many as fit you. Now, I have a particular interest in seeing how two of these terms compare to each other. Once the poll closes, I'll give you my my perspective on this. And one term I'd personally like to see put to rest. Okay, whenever you're ready, Maureen. Okay, most of you say case manager, and followed closely by care manager, and then all the others are pretty even, slow. I personally would like to see case manager retired, because the primary reason that does not put people at the center of what you do. It puts the process, the paperwork, the bureaucracy at the center. I think care manager or social worker or clinical coordinator, or even utilization reviewer. Well, utilization reviewer, that seems a little squishy. But I think if we're really going to be person-centered, I think case manager does not meet the order. So now the polling is over. So those of you who need to go back to take a snooze, go ahead. Important but not sufficient objectives of being I'm going to say care manager for the rest of this session. I know not everybody is involved in hands-on care management, but that's the term I'm going to elect to use. Issues around safety, security, and risk minimization are very important, but they're not the drivers. They're not sufficient to be effective in case management, because in case management, there's a spectrum of functions ranging from providing direction. That's on the very foundation, telling people what to do. Next up, a little bit more in terms of putting the person at the center of things and recognizing them as dignified individuals and maximizing their independence and choice, is making recommendations. Then providing information so they can make their own determinations. Next is to advocate around options, maybe even try to be influential in one or the other, but not being directive. Next is to educate, provide all the data, the information, the strategies that are important around whatever problems or issues need to be resolved. And most importantly is to empower individuals to act to the fullness of their own capacity, whether it's physical or psychological or functional. Now here, I'm going to switch gears now. We used to talk a little bit about Dignity Alliance Massachusetts, which just a year ago was not in existence. We were birthed in the very beginning of the COVID-19 pandemic. For those of you here in Massachusetts, and this may be quite familiar, but near the beginning of the pandemic, the state administration, specifically through the Executive Office of Health and Human Services, had this notion that if they put everybody who needed post-hospital care who had COVID-19 into specific care facilities, that would minimize any transfer of the infection. So they identified about a half a dozen nursing facilities throughout the state where they wanted to relocate, and I say that politely, it's really dislocate, to evict existing residents from their facility homes and move them to other nursing facilities, and then create entire buildings where people coming out of the hospital with COVID-19 could be cared for. They started with one facility in central Massachusetts, and several of us who've been around for a while became very alarmed with this undertaking. We thought it was bad for a number of reasons. First of all, it trampled on the rights and the dignity of the people already living there. We thought it was bad public health policy, and we thought it was going to be totally ineffective. Unfortunately, we were proven right fairly quickly because after our advocacy and a few other folks in a bad experience with the first population, because once they transferred residents from the first facility, they found out that a significant number of them were already infected with COVID. And when they decided to prepare the second population, as they did pre-testing, about half the population was already positive for COVID. So that effort stopped immediately. And the half a dozen or so of us who got involved and were concerned about this said, we cannot allow a return to business as usual, especially in long-term care facilities, at the end of the pandemic. At that time, we thought the pandemic, is, I think most of us did, was just going to last a few months. But we got together virtually, and very quickly became familiar with Zoom. And from what was initially about 6 or 7 of us, we now are functioning with about 150 active members. And when we have our bi-weekly Zoom sessions, we're generally averaging about 50 participants. But what we're focused on is the transformation of long-term services and care and support systems here in Massachusetts, and frankly, outside of Massachusetts, into a 21st century model where they're emphasizing self-determination of individuals to the extent that they have that ability, giving people full choice of different options for the way they get the necessary care and services, providing as much autonomy as possible, and for every single person, no matter what their level of functioning, offering them the full amount of dignity each and every one of us deserves as a human being. Frankly, I don't think any of us would want anything different for ourselves or anybody that was close to us in terms of our family and friends. So we as a society should offer this to everybody. Here's our mission statement. Dignity Alliance Massachusetts is dedicated to transformative change to ensure the dignity of older adults, people with disabilities, and their caregivers, because the caregivers all too often are underappreciated, and they don't receive the proper dignity, whether they're unpaid family members or within social circles, or compensated caregivers in our both facilities and the community. We are committed to advancing new ways of providing long-term services, support, living options, and care while respecting choice and self-determination. Through education, legislation, regulatory reform, and legal strategies, this mission will become reality throughout the Commonwealth. And as I said, it could be also in other jurisdictions. We've structured ourselves. We have a coordinated committee, but we also have very focused work groups, facility-based care. We look at operations, we look at regulations, we look at statutes affecting that provider type, home and community-based services, which is a very broad expanse, everything from skilled in-home care to telehealth and community care such as adult day health and PACE programs. Behavioral health, both psychiatric issues as well as substance use disorder, and various dementias. Housing options, both accessible housing as well as supportive living and affordable housing, and also housing for workers. And our other two work groups are more on terms of necessary logistics around communications and legislation. During this past 12 months, what we have produced, and I say it's all been virtual, we have yet to meet each other in person, but we've developed a lot of output. We've endorsed at this point, probably between last legislative session and the legislative session that we're currently in, probably close to 50 different legislative proposals. We've had testimony on a number of regulatory issues, both as well as in legislative oversight committees. We produced a number of policy papers. We produce a weekly compilation of timely information on long-term services, support, and care called the Tuesday Digest. It goes out electronically. We just yesterday issued a 36th weekly digest, and I'm going to mention at the end, if anybody's interested in receiving that, you can sign up for a free subscription. Multiple media releases. several broadcast interviews both on television as well as radio. And what we're looking to do this coming year, in addition to carrying on this activity, is develop periodic discussion groups and educational sessions and become much more active in social media. We really don't have a presence on Facebook or email. We're looking for some members who have that as a skill set. So if anybody's interested in getting involved with Dignity Alliance and has that interest, please let me know. Opposition. So what we're currently have done over this past year specifically is opposition to creating COVID-specific care facilities, which I've already covered. We got very involved with the closure of Fair and Care Center out in Franklin County in the western part of the state, which is at the time was the state's only psychiatrically capable long-term care facility, and they wanted to close that facility and transfer all the residents to what's now called Mission Care in Holyoke. In the midst of the pandemic, we got actively involved, and won't go into the details on that, but we had weekly phone calls with all the parties for almost 6 months, and I think we played a very positive role there. And all the residents were just finally transferred, the last of them last week, and not one of them experienced COVID. And that was one of our main concerns, plus a number of other concerns. We're currently actively involved with the Holyoke Soldiers Home replacement. The state wants to replace the current home, which I think many folks know there was a very bad experience early on with over 70 residents there dying of COVID. And it was an old facility which should have been replaced a long time ago, but they want to more than double the number of inpatient beds, and to the tune of $400 million. We absolutely think a lot of money needs to be spent. $400 million is fine, but not to build 200 plus beds in one location in Holyoke. We think that needs to become a home and community-based center and put small house model facilities housing between 10 and 14 veterans throughout communities in Western Massachusetts. We're actively advocating for the expansion of home and community-based services. We just submitted 14 recommendations to the state in response to requests for information from the state's receiving $400 million from federal funding as a result of the American Rescue Plan Act, and we're giving them ideas how to spend that. And we've advocated successfully for the expansion of housing vouchers to help people come out of nursing facilities. And one of the barriers for them coming out was they didn't have access to affordable, accessible housing, and the housing vouchers are helping to provide that. What we're currently working on now, here's our priorities: single occupancy rooms, and I'm really happy to hear Jamie started that conversion down in her facility. We continue oversight of the long-term effects of COVID-19, both on residents and staff. We're actively involved with frontline worker support, both in facility as well as in home and community-based settings around compensation, work environment, and making sure that they have PPE, and actively involved in encouraging vaccinations. Continue to advocate for affordable and accessible housing, as well as a lot of advocacy around behavioral health resources. And we're becoming very involved with other nursing home closures here in Massachusetts. 3 have recently announced, and we're working with the state to become an advocate in making sure that that process goes smoothly and the residents are treated with dignity and their choices are recognized. So I'm just closing with this. Some of you might be familiar with this saying, nothing about us without us. It comes out of the disability community. And I think that should be a hallmark of the work of good care managers, that care managers do nothing on behalf of the people that they're serving without actively involving the client and family members and those that are significant around the person. My contact information is here. That's our website. And if anybody's interested in learning more about Dignity Alliance Massachusetts, becoming involved, or if you just like to receive the digest weekly, then you can get in touch with me. And I want to thank Maureen, Charlene, and Irving for inviting me. I think this is very timely, and and everyone on this call, I know you're doing critical work, and it's more important now than ever that we keep the people who need our services at the center of our focus. Thank you.
Thank you, Paul. Well done. And if Jamie wants to come back in, I don't think we could have had, for this session, I don't think we could have had better bookends for the overall topic and agenda item that care managers need to tackle. They're right in the middle of it, for health and social care for the aging populations. I want to focus on, to get us started in this conversation part of this presentation, I want to focus on something that Jamie said, which is bookmarked by something that Paul brought up, very important issue. Jamie talked about task avoidance among the target populations, where if you've all seen, and many of the audience have seen, the enormous stack of paperwork that is given to the advisor, family member, friend, relative of a person being discharged from a long-term care center. No wonder they're avoiding the tasks associated with pawing through all of that stuff. They're just still trying to figure out, where do I get a walker for mom? And here they are dealing with an enormous stack of material. So it's that task avoidance issue in transition. And yet here we have Paul talking about the Dignity Alliance, and specifically talking about the issue of self-determination. So the question is, for the two of you, how do we bring those two things together in a realistic model so that dignity and self-determination is supported and buoyed and nurtured, while at the same time moving people through all of the tasks that the system and the processes and the medical and social and regulatory environments needs to get completed? How do we do that? I'm going to put it first to Paul and then ask Jamie to weigh in.
The very good question, very astute question, Irving. And I'm thinking back to when I was both Secretary of Elder Affairs here in Massachusetts, and also when I was the Executive Director of North Shore Elder Services. And I would be asking my staff, when we had a particular requirement or a process or procedure, I said, why are we asking people to do this? What's the purpose? And can we do it any differently or easier? So I think what we really, to focus on the dignity of every individual and to get the job done, is we need to constantly ask, why are we doing this particular procedure, asking for this form? I mean, I recently, I just had hand surgery a couple weeks ago, and the number of papers that I was asked to sign was inordinate, and I read none of them. They just said sign, 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 sign. Now that wasn't dignified. That wasn't informed. That wasn't efficient. But I get the paperwork done. So I would say, let's take the time to don't keep on adding on another layer before we examine why it's being used, and if there's steps that we can eliminate that have been around for a while.
Jamie?
Okay. So self-determination and the being overwhelmed with the process, right? That's what the task avoidance. I think the key to it comes from having real conversations with the client, the resident, having real conversations and developing a plan, strong communication. All right, these are the services that are offered in the community, and this is how I can help you. And then having real discussions on how, the process of each one of those services, and dividing up tasks so the individual does not feel overwhelmed.
So those real discussions emphasize the other point, the other issue that this observer extracted from the presentations. All of this requires people. And we know right now that the labor market is white hot, that the demand for individuals exceeds the supply, and we can muddy the water with conversations about why people aren't coming back to work, but that's really not the issue. The issue is that we are in a business that requires carers who will have that conversation that Jamie talked about, and carers who will engage, as Paul was talking about, with administrators, with other people to say, do we really need this form, or why must we fill this out twice? Why isn't there a central database to store and sort this information? So I want to raise the issue, and I know that there's no single one answer that we can certainly arrive at here tonight. But for each of you, what is the source? Where will we find this workforce? How will we source them? How will we recruit them? Education is a major theme of this presentation. How will we educate them, and how will we retain them? Jamie?
Yeah, staffing, staffing has been a crisis, and I don't even think it's just our industry. I think, right now during this pandemic, the most important part, though, I think we need to focus on is there has to be radical change. Individuals in long-term care facility, and that's what I can speak to. I've heard the media say it is the most dangerous job in the nation right now, right? It's the most dangerous job. And yet let's just, think about those who are closest to the risk and how much they're being paid. There needs to be radical change in Medicaid funding. Once that's tackled, I think that we're going to see a shift. I think we're going to see a shift in that staffing shortage.
So more money, is that the answer?
More money, I know.
Paul?
Well, this is going to sound trite. Dignity. I think we need to treat every individual in the caregiving process with dignity. And that part of that is, yes, paying them properly, so more money, but recognizing their essential role. I'm going to answer this in two ways. If tomorrow Jamie's nursing home said you can only have half of your staff show up for work, half of it could be all the certified nursing assistants, or the other half could be everybody else. Who would you want to have show up to provide the care for the next 24 hours? The administrator, the housekeeping staff, all the other folks. They're necessary, important, but are they sufficient? No. The CNAs, if they showed up, first of all, they have the most intimate knowledge of the most personal care needs of each individual. And while maybe they're not up to their training in terms to do every other task with every I dot and every T crossed, they could do it sufficiently for the next 24 hours to make sure those people are well taken care of. They could prepare the food, they could meet all their personal needs, they can interact with them, and frankly, they could even give them their medications.
Great.
And so that's number one. The other quick way I respond to this is when we were involved with the closure of the Farron Center, moving everybody, we had one of the advocates who happened to be an attorney who was a guardian of 6 of the residents advocate, and he was adamant, saying that it was not sufficient just to have the written care plans be transmitted from one facility to the other, but he wanted not one, but 2 face-to-face or person, since it could be virtual, communications between the existing staff and the receiving staff with the CNAs involved out of the sending facility, because they had the most intimate knowledge of those residents. So I would say the CNAs, we need to start at the bottom of the staffing order and put our focus there and then build up.
So this brings us into another seething cauldron of debate. Paul, thank you very much. Because pre-pandemic, one of the topics that had been bandied about, imported from other service sectors, is the so-called universal worker, which is what you were generally alluding to in the flexibility of role and the capability, the capacity, the hard skills that the CNAs would have to perform these other tasks, which has been bandied about now for at least 2 decades. And yet, on the other hand, we have creeping regulatory pressure. And even in the Q&A here tonight, we have people suggesting that we need staffing ratio regulations. So staffing ratio regulations imposed on Jamie's lack of staff period paragraph, where does that get us? So I'd like you, Paul, first, and then Jamie, to talk about this juxtaposition of the need to be flexible about staffing, the need to be extraordinarily creative, not just in the peri-pandemic period, say that 10 times real fast, but in this time, not just to be very flexible, but going forward, because it's clear we're falling off a demographic cliff. All of the OECD countries are. We can see what's happening elsewhere.
Yeah.
So how do you juxtapose those two things, Paul?
Well, sort of a couple of bullet points in response. First of all, if we were in a perfect world, we wouldn't need to have ratios because every provider would do exactly what was needed. Unfortunately, we're not in a perfect world. So I do think ratios are a necessary floor. And I know every provider on every day is not going to meet them, but that has to be aspirational. And that needs to set the standard. I would say that the other part of the shortage that we're going to be dealing with, Irvin, is in fact, folks may have seen the news reports earlier today that the birth rate in the United States is now at a historic low. So we're not replacing ourselves. We're not, and we're not getting the immigration population coming in, and they are the primary source of our direct care workers. So as our population of those who need the personal support, whether they're frail elders or people with disabilities or others, that's rising, and our caregivers are declining, and through other reasons we're pushing them away. But I would say that we really should do everything we can to fully explore widespread use of universal workers. And I just put this little piece of information out there. During the pandemic, the providers who followed the small house model, often called the greenhouse model, generally 10 to 14 residents in one community setting with universal workers. So it's the same people are engaged with the same population. The rate of COVID experience, both in terms of positivity as well as significant illness and death, significantly lower than other settings. There's a number of factors involving their smaller size populations, but the fact that we have relatively few people interacting, a very significant factor.
Paul, you do that so well. You always bait the hook with the last topic, and you know, so we can get into that separately. The small model is broadly admired. Its value in infection containment and control in this recent pandemic was certainly validated. And frankly, from a data analyst statistical point of view, duh.
Yeah.
Of course.
And the practical is we're not going to overnight going to be able to create all the small houses. But
not only are we not only are not going to be able, but the model doesn't work because you can't get it paid for. It,
No, but-
economically, it doesn't work. in
Yeah,
the current context.
no, it does work if we had the willingness to finance it.
It comes to political will. Absolutely. But Jamie, take it.
What can I just say? What Jamie has started to do with the transformation is exactly what needs to be happening with existing facilities. We're not going to turn a 120 bed facility into a 14 bed facility, but you could start making the private rooms and accommodate folks that way.
So let's you and I agree, Paul, that we will do a long-term care smackdown in a month and invite this audience, and I'll show you the data and you can show me your data and we'll have at it. Jamie, please respond to this issue of
Yes, and as a long-term care administrator, I agree with you. I agree. And society has to start valuing the elderly population. I mean, we just have to say the ageism needs to be spoken, right?
Yes.
Okay, so where were we? Staffing ratios, that's where we were going. Staffing ratios. So I understand the idea of staffing ratios, but I think it's really important for us to understand staffing. We're in a staffing crisis. We don't have the bodies to meet that. So what does that mean at the end of the day? It's also important for us to educate ourselves on staffing ratios and what that does to quality care. I have to be honest, if you look at the research, staffing ratios does not determine quality care in the nursing home setting. If you look at the states that do have the staffing ratios, look at the outcomes, look at the CASPAR reports and pull up those star ratings. You know, currently here in Rhode Island, we don't have a staffing ratio. It's underway, but but look at our quality measures. And I think that that's meaningful information to be aware about.
So the other thing we need to be aware about is the time. And I think we have come to weigh in here, Charlene or Maureen or somebody. I think we've reached the end, haven't we?
Irving, this is Doug. Thank you.
Hi, Doug.
Just want to remind our attendees tonight, if you have questions, please use the Q&A section to write those questions. Do not use the chat because only the panelists can see the chat. So if you have questions, now's the time. Put them in the Q&A and we'll get your answers before the end of the half hour. Thanks.
So are we?
We have about another 10 minutes if you want to go.
Okay. So going back to the Q&A that I see here, one of the participants offered this question: how do you convince a client to make decisions that benefit themselves? This is a great question. Behavioral economists have spilled buckets of ink about this. Many times, due to growing old, people have a hard time processing and making decisions. Okay, I shouldn't do that laughing. I should read it. Many times, due to growing old, people have a hard time processing and making decisions. Mm-hmm. I do. So how do we professionally, lovingly, thoughtfully manage an individual, and it's really a family very often, even if it isn't a biological grouping, it's a family. How do we manage them through these difficult decisions? Jamie, as a social worker, I'm going to turn this to you first.
Sure, I'll be happy. So I always come from a standpoint to ask a lot of questions. I sit with them and say, what do you know about your disease process? What do you know about the services that are out there? What is your vision for this stage of your life, or as we navigate through the next phase of their life? And you know, to be honest, when my staff ask me when I go to different conferences on behavioral health, this comes up all the time. We know what this person needs and they won't do it. So how do we make them do it? You can't. I know a lot of my friends are smokers. Now I know that, and they know they shouldn't do that, but it's their choice. And I think that that's what we need to get back to. So Paul said it best: autonomy, self-determination. We need to provide the client, the patient, the resident with education, and we have to discuss risk, and we have to have real conversation. But at the end of the day, it's their right to make that determination.
Yeah, I agree with that. And first of all, Irvin, I'd say you don't have to be an older person to find it difficult to be making decisions. I find that happens with virtually people of any age. It was, among other things, you have the emotional overlay that's usually associated with many of the problems that you're trying to solve. I would go back to that that array that I showed. And don't direct people, because if you immediately start by telling people what they ought to do, they're going to get their back up. I'd start by giving them as much information as possible, being a coach, being an advocate. Give people options, give people choices. I remember when I was getting my MBA at BU, the marketing professor would give the example of how the airlines did it. They came up that people were complaining about the food that was being served. And what they started to do was give people two options, same food, but they gave people choice. And once they had a little bit more control over their decision, suddenly they like things a lot better. So I'd say give people their choice. And the last thing I'd say, and I'm thinking of a colleague that I had who was she has a disability herself, and she was the director of one of the independent living centers here in Massachusetts. She says, we have the right to make mistakes.
Amen. Amen. Well said. And indeed, we are all defined by the errors that we do. So there are a few other questions here. A few are actually comments or observations. In long-term care, the margins are 0 to 3%. Jamie is absolutely correct. Things won't change without better reimbursement. Completely agree. I personally have, anyhow. And then another comment, many clients will need to pay for the services they will need. So forgive me. Many clients will need to pay for the services they will need, and they will decline those services due to money, due to financial issues. What do we do? Well, uncharacteristically or a little bit out of form here, I'm going to make an observation. The United States is the only country in the developed world, in the OECD countries, that doesn't have a federally supported long-term care insurance program. And that's exactly what we need. And we will get there, but there will be an extraordinary amount of political toing and froing before we finally get to the ineluctable fact that we can't afford to continue doing what we're doing now without causing still further damage and embarrassment, frankly. So those are the questions. I want to thank Jamie and Paul for being willing, for having clear and well-formulated points of view, and for expressing your opinions so clearly and so transparently. We needed transparency, and this is what we got. So with that, I want to thank the participants. I haven't seen the numbers drop. So so we've done a good job. We've held the audience. And with that, I want to turn the microphone back to, I guess, Maureen